All right, just like always, if you have an anxious patient, really strongly consider the lights and sirens thing. We want to get them there in a hurry, but we don't want to make it worse. So keep that in mind. All right, history. Um, be looking. Is there anything in their history that would tell you what's happening is normal, if you can consider it that, or that might make this worse? Right? History of stroke, history of hemorrhage, aneurysm, and etc. And if you can't get history from the patient, as always, find it from elsewhere if you can. So obviously you want your patient to stay still, not move your head or neck, right? We're going to do most likely, depending on the mechanism of injury, you're going to do a systematic head to toe full body scan, unless you know it was just strictly a head injury. Problem with that is most common things that lead to a head injury are going to be full body traumas, right? If you sustain a fall, right, even a smaller fall, even a shorter fall, it's not usually just the head that sustains damage. If you are in a car accident, it's not usually just the head that sustains damage. So keep that in mind. A lot of times when head and neck injuries are involved, you're going to be doing the whole body scan, not just a quick focus. Didn't move, sorry. Get vitals right away. Why do we want baseline vitals? You know the answer to that. Right? We want to compare. So use monitoring devices. Use set your blood pressure monitor to repeat. Right? Keep the pulse ox on so you can see what's happening as they go. Right? You can monitor in real time any changes to vitals. Okay. DCAP BTLS. You know what that is. CMS. Right? PMS, CMS, whatever you want to call it, in all extremities, right? And we're going to talk about that more and more with splinting, with everything else. Check CMS, then move the patient, then check CMS again. You can't check CMS too much when it comes to injuries here. All right, so what are we looking for as far as head injury goes? Level of consciousness, that's the most. If they're not answering properly or slurring their words, right, or seeing things, that's the most reliable indicator of a head injury, right? We like I said, different collisions, different amounts of force can cause concussions and head injuries in different people, but the single most reliable is the decreased or change in consciousness, right? Look for leaking blood or cerebral spinal fluid. We'll talk about that here momentarily. And check the pupils, right? Pearl. We want them pearl. If they're not pearl, that's usually a problem. Okay. Pearl, technically, you know how that goes. We've had that conversation. Halo test can look something like this, right? If we see blood coming out of after a head injury, not just the bumped nose, but a head injury on nose, ears, or anywhere it shouldn't be coming out of, we're going to loosely cover it with gauze, take a look at it, and you'll see this halo around it where you can tell it's not just blood. That's a bad sign, and that's something you want to let, as you're taking this patient in, let trauma know positive halo test. Okay. Neurologic examination, use the GCS, right, and note any changes. Okay, not anything uncommon. There's the GCS again. We've been over that a few times, and we'll continue to do that. Remember, 13 to 15 is pretty close to normal, right? Once you get down 12, 13, that's usually indicative of some major issues, and you get down below 9, there's major problems, right? We've been over this. Spinal examination, DCAP BTLS as always. PMS, CMS as you go. Anytime you have pain or tenderness on the spine or along the spine, that's a bad sign, right? That's possible damage. So note those, right? Those would be notable findings. Okay, other signs and symptoms, numbness, weakness, tingling, right? Those are neurologic symptoms. That's what we consider those to be their nerve issues. They may be localized, they may be spinal, we don't know, but we're going to document those as neurologic findings. Okay, reassess, do the same thing, right? Check everything you checked before, check what you did for the patient, check any problem areas again and again, right? Every 5 minutes until you get there. What can we do for the people, right? Basically, all we can do is monitor when we're talking neurologic issues. Give them oxygen and monitor. Okay, so if you notice deterioration, keep asking them the same question. Do you know where you are? Do you know where you are? Do you know where you are? Okay, what time of day is it? Where are we going? Where were you going? Right? Keep asking them. You may notice some deterioration. That's a positive finding, right? A positive sign of problems. Communicate. Tell them who's coming, right? You're going to. They're going to have a trauma team waiting, if not a chopper. So you want to have all your ducks in a row to give them, right, in your report. What are we going to do? Airway first, right? Just like always. ABCs. Just like always. Airway, breathing, circulation, or CAB, however, whichever way you want to look at that. To control the bleeding, you control, maintain the airway, make sure they're breathing properly, and then just keep monitoring that patient. Okay? Airway, we're already doing it. Inline neutral position, that's C-spine, right? That's what you're doing when you have C-spine. Okay? Suction, remember head injuries can cause vomiting. So have suction ready at all times. If you think they have a head injury, you should put them on oxygen to keep that blood oxygenation as high as you can. There's some C-spine. Got to have a nice picture. Okay, if the patient's cardiac arrest, just like always, we do CPR. Right? ABCs. If the heart's not pumping, that spinal injury is not a problem, right? It's a problem, but it's not the main problem. If the heart's not pumping, they're dead anyway. So as always, do that. Control bleeding from a scalp laceration. You know, if you don't suspect, remember we talked about pressure earlier. If you don't suspect fracture, you can put pressure on that wound. If you suspect that there is a fracture, you need to be a little careful with that. Shock, we know shock. Right? Cushing's triad. This is bad. When you start seeing this Cushing's triad, which is blood pressure going up, heart rate going down, and respirations that are not normal, irregular, right? And we've described irregular before. It doesn't mean fast, doesn't mean slow. It means not rhythmic, essentially. Then we start to work. That's where you're going to start bagging that patient. This person is in big trouble. Okay, so always we'll spend a little time talking about Cushing's triad. You got to remember what that is. Okay, what do we do when we come into these injuries? Standard precautions, as always, right? Keep the airway open, immobilize, right? If the head is not neutral and inline, okay, we don't want to force it. We want to get the head to neutral and inline, but we don't want to force it, like against, if there's resistance, don't force it, okay? So stabilize them in that current position if that's the case. Okay, when we start forcing things with head and neck injuries, we start making things worse. All right? So there's the jaw thrust. All right, C-collars, right? We put C-collars on anybody who has a possible spinal injury. You're going to size it to fit properly, right? And we've worked on that. And even afterwards, if you put it on and it's the wrong size, take it off, redo it, right? It needs to be the right size. It might take a minute, but we need to support that C-spine, right? Advancing forward. Okay, supine patients, we want them on a long backboard, or now the vacuum mattresses. Most people don't have them, but they're coming along. So log rolls, we're going to practice that. And if possible, you can slide them on, but that's not generally thought to be a very safe method if you've got a spinal injury. We've practiced a 6-man lift. We'll go over that again too. That's also another option. So different ways to do that. We'll practice them. Vacuum mattress, essentially, it's a nice soft pad you put them on, and then you suck the air out of it, and it adapts to this curvature of the person's anatomy. It tends to be more comfortable than a backboard for patients. Okay, if they're sitting, we're going to use a short backboard, the speed board. We have gone over that. We haven't spent a lot of time on it. We're going to as we get closer to practical time here. We want to use that to get people out of a car or anywhere where they're sitting, unless they're in imminent danger, right? There's danger of fire. You're on the highway, cars buzzing by, you're going to get hit, etc., then you want to be a little more cautious. Okay? If they're standing, we've done this earlier this year. We'll do some more. Standing backboard. That's that kind of trust fall thing we did earlier this year. And again, they say this over and over again. If there's if we have a head injury, neck injury, pain, MOI, whatever, if there's a possible head injury, make sure that we stabilize the spine. Okay. Headboard, we've showed you this. They've kind of fallen out of favor in favor of those speed boards, but we've got one. We showed it to you before. We'll show it to you again. Long backboards, you know about those. Okay, helmets. When a patient has trauma, head trauma, neck trauma in a helmet, motorcycling, football, etc., oftentimes we leave the helmet on because that does a great job of keeping C-spine, keeping their head stable. You can tape a helmet right to the long backboard. It's pretty slick. So oftentimes, usually we leave the helmet on. Okay. If it covers their face, their full face, we want to try to get it off. Football helmets, you can take the face mask off. A lot of motorcycle helmets, the front will flip open. But if you can't do that, you may have to take that around. Okay. So on there, you can see the circumstances in which you'll remove it. What do we do it? If we are removing it, we want two people. Okay. I might see if we can grab a football helmet and try this and show you how we would remove a helmet. But you want to, from underneath, right, from down by their shoulders, you want to hold C-spine and then take it off that way. We'll go over some techniques. We also can cut the helmet off. Okay, not ideal, but it can work. It takes usually a little more time. Or taking it apart, we can basically take it apart, and if possible, we cut the helmet off or slowly remove it. So disassemble it, take it off, and